Hello, everyone. On behalf of Karyopharm Therapeutics, I'd like to welcome you to our program today. My name is Laura Scott. I'm a senior Karyopharm nurse liaison. I'm honored to be your moderator and host today. With September being Blood Cancer Awareness Month, we have an exciting program planned for you. Over the next hour, we are so glad that you could join us for this very important topic. Blood cancer, also known as a hematologic cancer, is a broad term. It encompasses multiple myeloma, leukemia, lymphoma, myelodysplastic syndrome, and myeloproliferative neoplasms. Approximately 1.3 million people in the United States are currently being treated for or in remission with one of these diseases. It is estimated that an additional 186,000 people will be diagnosed with leukemia, lymphoma, or multiple myeloma in 2021. Before we get into our discussion, I'd like to welcome all of our panelists who have joined me throughout the country. First, I'd like to welcome Jenny Ahlstrom. Jenny is the founder of Myeloma Crowd. As an 11-year multiple myeloma survivor, Jenny has set out to educate patients and encourage them to enroll in clinical trials in order to advance cancer research. Next, I'd like to welcome Srinivas Tantravahi. Dr. Tantravahi joins us from the University of Utah Huntsman Cancer Institute. Also joining us today is Dr. Sumit Madan from the Banner MD Anderson Cancer Center in Arizona. Thank you for joining us, Drs. Tantravahi and Madan. Rounding out our panel today is Dr. Daniel Verena. Daniel is an oncology nurse practitioner at the Mount Sinai Hospital in New York City. To our audience members, if you have any questions throughout the program, please put them in the chat box and we'll do our best to answer your question at the end of our program. Welcome again, everyone. Thanks for joining us today, and let's get started. So to answer the question, what is blood cancer? I'm going to start with you, Dr. Tantravahi. What causes cancer?
Laura, thank you for having me today. I would also like to thank all the organizers for inviting me to this webinar during this month of blood cancer awareness. So I appreciate that. So as you already mentioned, broadly blood cancer includes leukemias, myelodysplastic syndrome, multiple myeloma, and lymphomas. These are some of the sort of more common blood cancers. When it comes to what actually causes these diseases, over the years we've figured out certain risk factors that increase risk of developing blood cancers, and some of those include aging. I think Dr. Madan recently pointed out in our recent discussion that age is one of the biggest risk factor for any sort of cancers, particularly for blood cancers. So a lot of our patients that we treat are in their 50s and 60s most commonly. And there are some of the risk factors, particularly for leukemias and also multiple myeloma to some extent, is that any prior history of radiation therapy or chemotherapy for other cancers. For example, women who receive radiation or chemotherapy for breast cancer have a higher risk of developing leukemia later in life. But, for most people, they ask in the clinics, like particularly young patients presenting with leukemias, we don't really have a specific cause, and it often bothers a lot of young people, like why me? So, but sometimes we also keep in mind that certain blood cancers can run in families. So if there is a family history of more than one member, we keep in mind the potential risk as a familial predisposition to certain cancers. I hope that answers some of the common questions that patients ask.
Thank you so much. And Dr. Madan, actually, would you add to that from a standpoint of, a familial tendency? Because I think that's important to understand on that cause.
Yeah, so, basically cancer is nothing but an uncontrolled proliferation of a single type of cells. Like for example, in myeloma, there's an uncontrolled proliferation of plasma cells. And that causes several things to happen in the body. And as far as risk factors, like Dr. Tantrawahi pointed out, in blood cancers, we don't really have per se risk factors. For example, in lung cancer, we know smoking is the culprit. In breast cancer, we know there is obesity, there is bad diet, saturated fats that can cause an increased risk of breast cancer. Certain viruses can cause certain cancers, such as liver cancer, etc. But in multiple myeloma, we don't really have one particular cause. The only thing that has been postulated, again, this was back in the days when we were in the Vietnam War, and Agent Orange that has been linked to several blood cancers, especially leukemias, lymphomas, and myelomas. So the number one risk factor still remains age. So think about cancer, it's these cells which are continuously dividing and they know when to stop. But in cancer, what happens is they lose their ability to stop dividing. So there is an uncontrolled growth. And so age is one of the biggest risk factors. We see patients as we age, they tend to develop more of the malignancies. Thankfully, multiple myeloma doesn't typically run in families. It's not one of the cancers that runs in families, unlike some of the other solid tumors.
Great, thank you so much. I really appreciate that input. Daniel, do you want to add anything additionally? And then would you also, Daniel, comment on how do you counsel patients on cancer prevention? Oh, Daniel, you're on mute.
Thank you again for this wonderful opportunity of working with this panel of experts. Definitely, I agree with both Dr. Madam and Dr. Vahi with its age, but we do also know that possibly, high exposure to pesticides, anything that can really interfere with, the DNA or dividing of cells, and it's like Dr. Madan says, it's a proliferation or dividing of cells over time and age. But as we get older, like we make mistakes in life, so does our cells, and unfortunately, sometimes that mistake can live on, and it doesn't make it a good mistake. Sometimes we learn from our mistakes and sometimes we don't. And that's somehow, if you want to think about how cancer wants to make its own mind. And really talking to patients in reference to, cancer prevention, it's hard to say, it's really looking at cultural lifestyles. So asking them, telling somebody to eat a healthy lifestyle, I think is I think the mainstream of what we say, but I always say eat as best well-balanced diet within your own culture. You can't switch, don't become a vegetarian or take out meats if you are like carbohydrates, which I adore. So, taking away every piece of bread from me would not be a very good idea, but eat a healthier lifestyle. Definitely like wearing sunblock, protecting our skins, because, we know that overexposure to sun causes skin damage and things like that. So really, and participating at every age group, participating in the screenings, going to see your primary care doctor, getting the appropriate screenings for your age group is very important. Following up with your doctor, I think that's the best thing that we can. And like Dr. Madan said, and Dr. Jawahi said that, there is some types of cancers that run in the family. So screenings might have to be scheduled earlier if there is a higher risk of a particular type of cancer, whether it's solid tumor or it's blood cancer, might be screened a little sooner if your family history is higher. And that's kind of how I advise my patients.
Great, thanks so much, Daniel. I appreciate that. And sticking with you too, Daniel. No, you came off or come back on mute or off of mute. But I'm going to ask you, what really does bring a patient into the doctor finally? What concerns them that you find are bringing patients in?
So that's a great question. So I think in all of our practices, we have a multitude of pathways that they'll come see us. And a lot of times, in most types of blood cancers, they might go see their primary care doctor. They do their general wellness follow-up, and then they find some abnormality in their blood work. And I will say nowadays, most of the primary care doctors are starting to do a lot of the workup prior to referring them to the specialist to kind of guide them to which specialist we'll see. So a lot of times we're getting our referrals from other practices, whether it's from cardiology or a general practitioner to us. And then we do get some specialty referrals from other outside oncologists.
Great, thanks, Daniel.
You're
Jenny, as a survivor of multiple myeloma, what were some symptoms that caused you concern that then led you to go ahead and seek a physician's opinion?
I think I actually had symptoms for probably multiple years before I even went in. I think this is really common. I think it's even common, I had a brother-in-law diagnosed with AML, and I know there were a lot of ignored symptoms. So one of the important messages that I think we should talk about is go get checked if you're having any kind of symptoms that are unusual. I had a lot of fatigue, but we had moved out of that. I think I actually got it from a virus while I was pregnant with my last child, because that pregnancy was so different than any other. And I had a bone lesion that wouldn't heal. And I had just a lot of fatigue, but we had 6 kids. So like, who's not fatigued with 6 kids? So I just kind of ignored it and thought it was normal, but these things were not resolving. I finally had, just kidney pain and some kind of kidney issues. And I finally went in to get a PET scan. And when it came back, the doctor just said, your kidneys are actually fine, but you've got lesions all through your spine, your pelvis. It's probably cancer. You need to go get it checked. And that was shocking because I was 43 at the time.
Yeah, there's a lot we can just say, I'm a mother, I'm busy, or I'm a healthcare professional, I'm busy, but the fatigue certainly is a common thread. Dr. Madan, will you give us some insight on how blood cancer is diagnosed, specifically speaking to multiple myeloma?
Yeah, so, again, picking up from what Jenny said, we have so many of our patients who are symptomatic. Actually, if I were to count, almost half of my patients have been seeing a chiropractor for bone pain. A lot of these patients have had bone pains that have not improved, that has not resolved. And like it was mentioned earlier, just doing your basic blood work usually picks up a lot of the abnormalities. So one of the first things that we need to do is, of course, do a yearly physical exam, because the yearly physical exam is going to do at least a CBC and CMP. So for myeloma, those are very, very important, because almost all the patients with myeloma would have some abnormality in the CBC or the CMP. So basically, we're looking at your hemoglobin, so the red cells. Patients with myeloma develop anemia, so that's probably one of the first things that we can pick up. The other abnormalities that we can pick up in the blood are dysfunctions or abnormalities in the kidney function. So an elevated creatinine can happen in approximately half of the patients. There can be elevation of serum calcium. So think about this cancer. It is leaching all the bones and the calcium out of the bone, so that excess calcium goes into the bloodstream and causes bad things to happen. So in terms of diagnosing myeloma, that's the first thing we do. We do blood test, CBC, CMP, and then patients with myeloma have an abnormal protein in the blood called an M protein, and that is detected by ordering a simple blood test called serum protein electrophoresis, which basically segregates the proteins out, and we see an abnormal amount of monoclonal protein. The other tests that we do in the blood are also analyzing, again, this abnormal protein free light chain assay. We do some other testing in the blood, beta-2 microglobulin, LDH, that is to stage. So that is the blood aspect of things. There is urine test, again, looking at these abnormal proteins. So these proteins are secreted through the kidney and they cause kidney damage. So we need to measure the amount of these abnormal proteins that are secreted through the kidney as well and cause renal damage. Number 2 is looking at the factory of these cells, so the bone marrow. This test becomes very important. We need to find out how many of these abnormal cells are in the bone marrow, and then we do some specialized testing on the bone marrow, such as the FISH testing, molecular analysis, etc. And that helps us to not only stage the patient, but also helps us decide how we would like to treat the patient, and also the long-term prognosis. How well do we expect these patients to do? And last but not the least, very important is, remember, bone damage happens in patients with myeloma. So we have to be able to assess bone damage. And for that, we need imaging in terms of either a CT scan, but better yet, PET CT scans. And also even MRIs sometimes may be required. So essentially, if you were to categorize, it's blood test, bone marrow, and then imaging.
Great, thank you so much. And, I understand with a CBC or a complete blood count and a CMP, a comprehensive metabolic panel, Dr. Tantravahi, I know there are similar methods, for diagnosing blood cancers, but can you add some insight for myelodysplastic syndrome and leukemias for us?
Yeah, absolutely. Most patients with myelodysplastic syndrome and leukemias, they seek medical attention either due to fatigue or easy bruising, or they've noticed a sharp decline in the exercise tolerance. And often that leads to a blood count. And so abnormal blood count is often usually what brings these patients to our clinics. We usually rely on a battery of tests to make the right diagnosis in this setting, because there are so many different types of leukemias and lymphomas and so many nuances in that. So one of the things that is critical in making a diagnosis of either myelodysplastic syndrome or leukemia is a bone marrow biopsy, which again includes not only looking at these blood cells and a battery of different blood cells under the microscope to look for abnormalities in how they are seen, and also evaluating the chromosomes and looking for mutations. So these are all kind of an important component of making the right diagnosis. In terms of lymphomas, often these patients present with a lump either in the neck or armpit, and a biopsy of the involved lymph node is kind of critical in making the right diagnosis.
Thank you so much. Yes, I think the bone marrow is always the source and gives us the most information that we possibly can gain for these blood cancers, either at diagnosis or even sometimes at relapse. So thank you. Daniel, do you want to add anything additionally that I feel like they did?
Absolutely. I agree with both. And one of the other symptoms that, and like Dr. Madan said, we look at calcium, anemia, and renal function, but, we kind of add the word I for infection, because myeloma tends to be an immunosuppressive disease. Most patients, sometimes they present with multiple reoccurring infections. So you have these 40, 50-year-olds that keep coming down with upper respiratory infections for no real significant way in the middle of summer. So it's something then, a primary care doctor might look into a little bit deeper too. So that kind of brings them in and testing them for that. And we do the same battery test, urine, and we're getting a little more sophisticated. Hopefully bone marrows will become less frequent in their styles, but definitely.
Yeah, I remember when we were able to capture a lot of information about myeloma in 2006 with the introduction of free light chain, and it blew my mind. I was so excited. You'd have to do always a 24-hour urine for Benz-Jones protein. So we're going to transition our discussion over to the importance of seeing a specialist. And just to gain some insight to your practice, we'll start with Dr. Tantravahi to give us some insight. Just how do referrals come in? You mentioned a few specialists that might end up referring, but we'll go through each of the healthcare providers on their referring process.
Sure, absolutely. Yeah, Daniel has already kind of highlighted that earlier, that the most of the referrals we get through are from the community, from the primary care. We also get referrals from other specialty providers that work within the system. And we also get referrals from the community oncologists, especially when they want kind of a more expert opinion, because being in an academic center, at least I'm privileged to have to be able to focus on one specific disease, like I do leukemias and Dr. Madan does multiple myeloma. So we have, what we call as new patient coordinators, and some centers call them as patient navigators. So they are responsible for triaging the referral and scheduling a visit with the expert that is focused on that particular disease. And we almost always see the patients within a week of receiving the referral. Sometimes I see them the very next day, and we do our best to accommodate, because some of these patients need immediate workup and make sure that, the disease, is not causing too many problems before we start treatment. So that's kind of the patient. I'm very grateful for the new patient coordinators, and they receive referrals from all over the place, and they do such a terrific job in terms of making sure that each patient sees the appropriate physician, so that there's timely diagnosis and intervention.
Right. No, thank you. And I think time is of the essence for sure in these diagnoses. So Dr. Madan, any additional input you'd like to share on that, direct referrals?
Oh, I agree with what Dr. Tantrawai says. It's essentially the same process, but time is of the key, actually. It's very important that we get to see these patients as soon as possible. If there's a diagnosis of multiple myeloma, these patients can very quickly go into renal failure, can end up on dialysis, or they could unfortunately have a bone fracture, which could be crippling. And that just makes it a lot more difficult to treat with all the tools that we have. So for me, it's very important to be able to see these patients as soon as possible. And so what I try to do is to get these patients in within a week. We don't need every last document. We can do a lot of this testing ourselves in our clinic, but the key is to prevent those patients from going into renal failure or from breaking a bone. So every time there's a new patient that comes in, I get an email that same day, and so I can decide when I need to see the patient. And the other thing that I've done is also my cell phone number is actually on the web, and so sometimes I get called directly, because these are patients that we can really help have a great life, have a great prognosis if we can start their treatment on time.
That's just so special that you share your cell phones. And even Daniel shared that with me. I just thank you for all you do, because it's almost like you never get a break. And I think that just shows your heart is in this. And I just really appreciate that of all of you. Daniel, I know many times the other clinicians at the referring practices sometimes call on you and say, hey, I don't quite understand what's going on. How do you best partner with the referring practices that seek opinions with your office? And we'll go into second opinions after this, but.
Absolutely. I think it's a wonderful opportunity that as healthcare providers, physicians, and advanced practice providers, that we have this collaborative, discussions on all patients. So if they see something odd, they call upon me and they'll send me the reports. And like Dr. Madan said, and Dr. Travahi said, we want to see them as quickly as possible. And I think, the beauty of life right now too is also that we can do these a lot of quick videos within a day over the web and talk to the patient, even if they can't travel, because we're getting a lot of consultations from different states and from different countries, and they want to talk to us as quickly as possible. And I think the opportunity to have these televisits has also helped us round off, so that we can even involve the local oncologist in that particular televisit and say, here's what we think you should be doing, and send me the reports. So I think having that collaborative experience and having them, unfortunately, they do always have my phone number, and being able to text and communicate with us in a fast note has really helped expedite the care of our patients. I think the blood cancer patients as a whole.
Right. Thank you so much. And then Jenny, how do you keep your physician care teams informed? If you were to go to a new specialist, what do you feel is the most crucial information to keep everyone on the same page? Oh, Jenny, you're on mute.
I just want to first emphasize the point about finding a specialist in whatever blood cancer that you have, because there's a lot of data in the myeloma space, at least, that shows that you live longer by seeing a myeloma specialist. It's absolutely critical. I think 80% of patients are actually being seen in the general oncology setting, but the value that the specialist brings in terms of determining your care, doing the right tests is just so critical. I actually saw this as a problem because, I've been to multiple facilities. I've been about 3 or 4 facilities in major academic centers as well. So how are they able to follow their patients? It's really tough. Like if you go somewhere for a couple of years and then go somewhere else, no one's got this complete record for you. So that's why we created a tool that we call the Healthtree Cure Hub. So you can put all of your information into a single place. And I've actually, we built actually a telemedicine portal inside of that. So I was trying to decide what to do next for therapy and did a consult with a doctor out of state while all these waiver restrictions were, open. And he said, that's the easiest second opinion consult I've ever done because everything was there, my labs, my genetics, my prior lines of therapy. And that's how I address it as a patient. It's really important that you put everything in a single place because a lot of patients are getting some testing done at an academic center, and then they're going home to get their infusion where a lot of their labs are run. So you're trying to combine all that data together for the holistic view. If you go get a second opinion, you kind of need all that together with you.
Right. Yeah. And then, going into that discussion about a second opinion, I'm going to ask Dr. Madan, how do you handle that when patients ask you, or if they don't want to offend you, to go seek a second opinion? How do you advise them?
Well, I think it's actually, it's very healthy. If there is somebody who wants to get a second opinion, it's, I encourage that. It's a good thing. If I were to be diagnosed with cancer, I would also like to get at least a couple of opinions, but at least I encourage the patients to see a specialist in that field, because like Jenny said, the outcomes are so much better if you're being managed by a specialist in that particular area, because, even though the numbers are huge, 1.3 million people, but if you compare blood cancer to solid tumors, it's still a small number. And majority of the cancer physicians in the community still treat a lot of your solid tumors like the breast, lung, colon, prostate. And so very important to seek, if you're seeking an opinion, try to go to a specialist who specializes in that particular cancer.
Wonderful. Thank you. And again, I think it's so helpful to get that encouragement from, specialists like yourself to encourage that maybe it's not you and it needs to be potentially someone else. So Dr. Tantravahi, how do you also counsel on second opinions?
Yeah, thank you, Laura. So the majority of the second opinions I see are the ones that come to see me or some of my partners. But occasionally I have my own patients that I follow that would require second opinion. Most times it is when I don't have any standard of care drug options, and if there's a specific clinical trial that we are not part of. But I had recently sent a patient who was interested in a clinical trial about a drug that we are not participating, but it was available at the City of Hope in LA. So those are some of the situations where I encourage my patients to seek out second opinion. But in terms of seeing second opinion from the community, I think, there are the couple of reasons why we see second opinions. One of them is, as I said earlier, that blood cancers are rare. And we are privileged in the academic centers to focus on one specific disease and gain more expert level of knowledge in that and kind of understand the field and the advances and participate in clinical trials. So when there is a sort of a dilemma in terms of the right diagnosis, particularly in leukemias, there are many different kinds. So I often see these patients for, more additional workup and make the right diagnosis. And then we also see second opinions for patients that are traveling from the community for participation in clinical trials. So I think it's very important. I'm grateful for the community physicians providing this care to, there are a lot of, we want to see everybody in the academic center, but we also understand that, people living in rural Montana, it's not feasible for seeing a specialist, driving 9 hours or something like that. So I think the community practitioners play a critical role in making the diagnosis and treating these patients, but we continue to reach out to our community partners so that they sort of understand when to send the patients to the academic centers. Fortunately, we are, work with some of the very talented physicians in the community.
Right. Thank you.
Yeah.
And, I know, again, there's so many wonderful reasons, and we're actually going to talk about clinical trials, but Jenny, I'd love your input because I know, again, patients sometimes hesitate. Is it the best thing to do to seek a second opinion? So what does that conversation look like from a patient peer?
Always consider seeking a second opinion. I was diagnosed in a general oncology cancer center here locally. But the right tests weren't even performed to get an accurate diagnosis. So they kind of made the mistake of saying, don't go to that cancer center in your city because they'll have you be doing X and Y. And of course, we hit the parking lot and that was our next call. In myeloma, it potentially is different for different types of blood cancers. And leukemia, I think you have a more set standard protocol that you might go through. And then you're in the clinical trial options. But in myeloma, there's so many different options you could consider that you really need to get a variety of opinions. And sometimes even in academic centers, people have different specialties. Somebody focuses more on stem cell transplant, or somebody has really good experience in cellular therapies. As a patient, this is your life that you're dealing with. And the difference between outcomes there's data around this, both from the Mayo Clinic and from the University of North Carolina, that you can live like 39% longer or 2 to 5 years longer if you are seen by a specialist. So it's because in myeloma, there are so many treatment options and they need to be combined and administered in the right way and in the right order for the right patient. So it's absolutely essential. And if your doctor is offended by getting a second opinion, you should probably seek out a different doctor. It's just so important. And you can love your local oncologist and they can administer all of your infusions and you can do that. But really, when you're making these core treatment decisions, either a diagnosis or a relapse, it's so critical for you.
You are your best advocate, right?
Yeah, you have to be. You really have to be, because they might not be aware of clinical trials that are open to you because they're not hosting them at their center. So one of my friends said, it's not fair that you have to advocate so hard for yourself. When you're a patient, you feel terrible, but you really have to, and you have to find the best of the best and to help you on the most challenging journey of your life.
That's right. Daniel, anything else to add?
No, I totally agree. I'm all for patients getting second opinions, whether they're coming from us for the community. I'll actually call other facilities. I'll reach out to my colleagues at MD Anderson and say, do you have these trials? And literally have my patient fly down there. So I have not, and I agree. It's almost like a dating game. When you date somebody, you ask everybody in your family for the opinion and your friends, do you like them, not like them? It's the same experience that you want with your healthcare team for your specific disease. You really want to be confident and who's treating you. And just like Jenny said, and Dr. Tajani, the community physicians are truly our support because they can't travel 3 hours each direction. But I think our philosophy in hematological cancers is that we're consulting and we're here to support our community physicians and guide them in the best way for our patients. No, they don't have to keep coming to our center, but the patient knows that we're there for them. And so is that community doctor know that we're their support. So I literally say, please go get a second opinion and then come back, because like Dr. Madan said, there's other clinical trials that are not at every facility. And I think giving best options, the buffet that's available for our patients and with the hematological cancers is the best process.
Right, absolutely. And so we've all already talked about clinical trials, but I'd love Dr. Tantravahi, give us some input from your perspective on when do you suggest clinical trials in your patient population?
That's a great question. You know, I want to treat every patient on a clinical trial, right? That's how we find new drugs, and that's how, you know, we make cutting edge treatments available. But having said that, as we are, everyone in the panel pointed out that it's not always feasible. But one general kind of rule of thumb is that when a specific treatment you chose is not giving the result that you're looking for, and then maybe a clinical trial may be an option in there. And the other reason also is when all the approved agents are, you're exhausted of all the approved agents available for a specific disease, whether it's myeloma or leukemias, then a clinical trial is very critical. And we do see sometimes patients doing really well on a trial, even though they had failed everything else before. So it's not, you know, end of the, you know, so that's why it's very important to talk to, advocate for yourself. All the clinical trials are available in public domain, and also reach out to the local academic centers and also your community oncologists. And many of them keep in touch with academic centers and fully aware of the clinical trial options. So as Jenny pointed out, that you have to be a great advocate for yourself, even though you're feeling yourself pretty sick, but that's really important to get the best care possible.
Right. And so much has, you know, certainly been approved in my years, 21 years of being an oncology nurse. You know, Dr. Madonna, I'd love to hear your input too on clinical trials, whether it's for, you know, newly diagnosed patients or relapsed patients.
Yeah, I think, again, you know, clinical trials are critical. I mean, the fact that we are where we are right now with myeloma is because we did so many clinical trials. And thankfully, we have, you know, every year, 1 or 2 new drugs that are getting approved, several combinations. And the reason is because we have clinical trials that support that data. So I think one of the things is when I discuss clinical trials with the patients, you know, one of the misperceptions is, all right, so am I going on this clinical trial? Is that it? So that's kind of important to address with these patients that, you know, no, this is, you know, you're probably in the first to third line relapse. So that's why you would qualify for this trial. Or sometimes we have trials even for newly diagnosed myeloma patients. So that's very important to understand. Some of the trials incorporate drugs which are already approved. So not every clinical trial is looking at is a phase 1 study of a new compound. There are, and there's very exciting compounds which you know, are going to make it to the space. But a lot of studies are just combinations of drugs that are already approved. So clinical trials are extremely important. It does not mean that it's the end of the road. It just means that we are looking at other options which we think could produce better results. So a well thought out clinical trial at any stage of the disease is actually the preferred option, even in frontline setting, as one of the questions that just came up.
Perfect. Yes, absolutely. And, you know, Jenny, I'd love your input on that too. You know, when patients ask you, how do I find what's available in my area? What is your advice to them?
Well, clinical trials, to just reiterate, I think clinical trials should be considered at every stage of disease, because sometimes as a patient, if I look at how to advance a cure for my own disease, a large portion of that is because I'm joining a clinical trial. It's important to know which one. I think clinicaltrials.gov has a list of all of them, but in my opinion, as a patient, it's a terrible website because it's too hard to navigate as a patient. I remember when I was first diagnosed and I got on and I started reading about 3 or 4 and I started to cry. Like, I don't know how to do this. So we ended up, for myeloma, on the myeloma side, we ended up partnering with a third party that helps you kind of sort through the clinical trials. And then for AML, we built our own clinical trial finder that patients can actually have, because it's such an important thing. Like when I look at my own treatment, I have probably 7 different combination options that I could consider at relapse for myself. And I'm joining a clinical trial. I'm participating in one right now because I see that's where the science is headed. And I want to take advantage of that. And it'll take 2 or 3 years to get everything approved. But I want to take advantage of that early because I've already seen some of the data. So some of it is you need to be able to look at these and kind of evaluate. So you need to keep up to date on what's happening, what's happening in immunotherapy, what's happening in the targeted inhibitors, what's happening. So, like if you wait to join a clinical trial till you're out of options, you will not be able to join a clinical trial because you won't be healthy enough to do it. So that's just some of the considerations that patients need to think about.
Absolutely. Appreciate that so much. Again, and so many patients listening in today are learning wonderful things from you. So thank you. Daniel, this is directed towards you. With a specialist team, often, there's a collaborative cadence amongst the team members, physicians, advanced practitioners, clinic infusion nurses. Can you share with us what your role as a nurse practitioner, how that fits in, and then what symptoms do you encourage patients to call you about?
Well, thank you. I think that's an important question. Absolutely. I think, as advanced practice, and I think as a healthcare system, we're like the hub of many, a lot of information. We're like your computer CPU. Everything is coming into one, and we need to learn how to process it. So you have your physicians that are speaking to you about a patient. You have the infusion nurse asking you questions. You have your medical assistants asking you questions. Your social worker, your physical therapist, all about, and the patient who's calling and texting you on your phones, asking the same questions. And I think that's important to be able to incorporate. And I think even Jenny could comment on that. Being a very good holistic care for a patient should be everything, dealing with the financial toxicities of what we're all going through, and the care and navigating even through a new institution, trying to find out, where do I go for a certain test, can be quite a challenge. So I think as my role, it's giving the best care and incorporating all the best specialists so that patient gets the best care going forward. It can be a challenge at times, because you're trying to manage a lot on a plate, but I think at the end, it's patient comes first, in my opinion, for that.
Absolutely. And then, just because a blood cancer might be part of your journey in life, obviously, survivorship programs are important. If you want to mention a little bit on that too, that would be helpful.
Absolutely. I think, and I think we even talked about it prior to that. I said, since I'm only 12 years old and starting myeloma when I was 1. No, but myeloma, when I first started treating myeloma, patients' life expectancy was very short. And the concept of a survivorship really was kind of this cloud. It was kind of the carrot in front of the horse. It was kind of there, but we may get to it. And I think it's wonderful that we have our patients living 10, 15 years. I've had a patient live 35 years with myeloma, and having that, developing a survivorship and creating a program to actually allow them to have that separation. I think patients have this separation anxiety because when they're newly diagnosed or at relapse, basically you're their whole world. You encapsulate them, you engage them, like you said, having children, you cover them, right? Mm-hmm. But as they get older and more mature and you kind of let them go to college, that empty nest experience occurs and you have the anxiety, and so does the patient. So it's you developing that survivorship program to allow patients to know that it's okay, that I don't have to see you every week or every 3 months, and guide them actually to start to see their primary care specialists too, to keep up with their normal healthy screenings, because they relied on us as specialists for so long. Right. That now it's time to give them back to the community. And that sounds like a very sad, crazy thing to say, but giving them back to the community and say, you are healthy enough now, please continue your healthy life, but I'm always here. Like Right. You're the parent. I will never
Absolutely.
go away.
Here you go. Dr. Madon, will you actually speak to that on the transition back to the referring physician and how you handle that?
So, again, just as Daniel mentioned, fortunately, the myeloma patients are living longer and longer. So, the average survival in the 1990s was a dismal less than 2 years. And now we're looking at, the standard risk myeloma patients can live several years. Clinical trials, they're living for 10 plus years. So it's good. So always, advise the patient to make sure that they do their cancer screenings to make sure, they're updated on they're up to date on their colonoscopies, their PSAs, their mammograms, etc. Because this is not a sprint, this is a marathon. And majority of the patients are going to do well. So that's extremely important. The only time I completely stop seeing a myeloma patient is if they would be like beyond 10 years or they're not on any therapy, which is unfortunately doesn't happen too often. I still like to see these patients at least once a year just to make sure things are going well.
Right. No, I think that seems pretty typical. And how about you, Dr. Tantravahi, that referral process and handing back over to that community practice? How does that look for you?
Yeah, I echo the same thoughts that's been expressed by everyone in the panel. There are some patients that I continue to co-manage, as Dr. Madan pointed out, that decreases the travel burden on the patients. So they continue to see the local doctor, and we oversee that every, depending upon the condition, whether it's every 6 months or every year. But there are certain conditions that we cure. And for example, sometimes patients with acute myeloid leukemia are cured after 5 years following a transplant. And these individuals I still follow once a year, but as Daniel pointed out, that I'm their parent, and then I send them back to the community, primary care doctor, so that they still manage their cholesterol, and someone is keeping track of their blood pressure. We don't do a good job. I admit that. So those are things that are important to allow the transition to happen.
Wonderful. Thank you so much. Okay, so in our final section, we're going to talk about the importance of advocacy organizations. I'd like to ask Jenny, what resources are available through advocacy organizations, and what are some of the most pressing needs that patients share with you that advocacy organizations can address?
Well, I think when we advocate, our number one message is get a specialist, and we've talked about that already. But if there's one thing patients can do for themselves to self-advocate, it's that. Outside of that, I know, at least for me, I wanted to know everything about myeloma because I'm being asked to make this treatment decision. I've never even heard of this disease before, and all of a sudden I have this responsibility. Like, what do you want to do? I don't know. What do I want to do? Show me the data. What's working best for patients. So that need kind of helped us create some of our programs, especially this data portal that we call the Healthtree Cure Hub. I think patients need education, whether they do it or their family members do it. Somebody needs to do it in their family, because the more you learn about your own labs, the more you learn about everything else. So we even created a disease university for both myeloma and AML. So patients could kind of binge watch their way through this education and get up to speed, because sometimes you learn a little bit at this conference and you learn a little bit at this webinar, and you're trying to put it all together, but maybe you don't have the time. Maybe you have, an acute blood cancer and you need to get up to speed really quickly. So I think coaching or mentoring platforms are also very helpful. And we have a myeloma coach program to do that. And then attending webinars like this are really important, because you learn a little bit at a time and you can stay up to date. So that's why we created the myelomacrowd.org website, because we wanted news and information to be constant and in patient-friendly language. So you're not trying to read a scientific article all the time to know what's happening in the disease space. And we have that on the AML side too now, these community programs that are just there to support and educate and inform patients, but also to invite them to participate in research. I think in the past, patients they were patted on the back like, oh, we're going to take care of you, but we really need you to participate in clinical trials, so they can do more than that to contribute to academic research. So, and we survey patients now on that platform all the time and invite investigators to submit their surveys, and patients can respond. And we just want the cycle to go faster. We are inpatient patients. We want to find a cure sooner rather than later.
Right, absolutely. Well, thank you so much for that too. And then Daniel, you know, a lot of times I'm sure family members, loved ones ask, what can I do to help? I just don't know what to do. What are some things you encourage family members to do to help their loved one during this
I
time?
think it's a challenge. You know, it's everybody wants to help but doesn't know how to help, and and I think the word cancer scares a lot of people. Besides being the patient who has the diagnosis, the family also experiences the diagnosis themselves too. So it's actually getting to know the patient themselves and seeing how they like to communicate. Some patients like a lot of information, some patients don't want to know, and it's getting that information. Who do you want me to pinpoint the conversation to? Do you want a family member or a support, or your partner or somebody, a healthcare supporter, be the one that we talk with the most? And then understanding that just sometimes silence is actually a healthy thing. So just being next to your friend or family member who has cancer and just sitting there could be enough, or just stopping by or leaving a note, or picking up an item. I think, just like Jenny said, there's a lot of other advocacy programs out there. Not everybody wants to be very visual about their disease or be in the support group, and a lot of other programs out there, from the MMRF or the IMF out there, has a lot of webinars or support groups that could be virtual. You don't have to be seen, because everybody experiences it, and I think everybody has to grieve in their own way through the process. And those experiences, like we can talk about, like the AA programs, everybody has to experience it. I can never say I know how you feel, because I'm not in that position. I can only say I've heard, my patients have experienced it. But it's good to talk to somebody through a webinar or an actual meeting, or through support groups, and say, how did you handle this? What were your tools that you did? Or, oh, your sister had this, like what happened? And I think when patients also do that, they can compare notes. And I always get that, oh, I heard this webinar and so in the waiting room told me this. But it's those kind of things that really help get patients and family members together. I always say it's a shared decision process. It's not, I'm very old, so I can say father knows best, but it's not doctor knows best anymore. I think it's collaborative across the board. And I think patients, like Jenny said, have to be the advocate, and they're actually sitting next to you in the driver's seat. They're not the passenger behind you any longer. It's them saying, your Google directions, you need to turn here, instead of me saying no and argue and say, no, we have to go left. So I think that's a very important process.
Right, absolutely. And, I'd also love Doctors Tantravahi and Madan's input on, how do you encourage patients to get involved, or decipher between really good information that exists on the internet versus misinformation? I'll start with Dr. Madan.
No, I think it's really important. Jenny and Daniel have summed it up very well, so I won't repeat the same things. I think these advocacy organizations are very good in terms of not just the clinical trials, but if we just go up to these websites and look at, just after every major meeting, a lot of these organizations have, the abstracts already published, or some information about what is latest in that was presented at this meeting, what we think is going to be the next drug that's going to be approved. What are the newer combinations that we think are going to work, where the disease field is heading. So I think that's really important to look at that, because you should always have, all right, what is next? What is my next step? And especially in a disease like multiple myeloma, all right now I'm in remission, but when the cancer comes back, which unfortunately it does, what am I going to do next? And there's several treatment options out there. So it's very important to actually, make sure that you stay up to date with the field. And number two is a little bit of word of caution. There is just to understand that, especially in myeloma, it's a very heterogeneous disease. So your cancer may not be the same as someone else's disease. So what may work for somebody may not work for you. So that's just something that has to be understood as we, work and deal with advocacy organizations too.
Wonderful. Thank you. How about you, Dr. Tandravahi? Any additional input on how to find and look for good sources of information?
Yeah, I think you nailed it earlier that there is misinformation as well. So Google is always an outright source to understand more about your disease, particularly for blood cancers, since there are misperceptions and misconceptions and all kinds of stuff. So advocacy organizations play a critical role in that area to not only connect to somebody like Jenny, who knows now a lot about myeloma, or talking to the peers who went through the same treatments, understand the process, understand the big picture, what it involves in terms of treatment. The other area that advocacy organizations play a critical role is that helping these patients to go through some of the hardships, particularly financial. In LLS provides grants for, paying for the copays, or, sometimes they help for travel reimbursements and things like that. So I can't emphasize enough how great, how fortunate we are to have these organizations to help through these patients that are in such a big need.
Thank you so much. Again, I think it's so much that the healthcare providers encourage, patients to seek these things out, because there's only so much you can share in your clinical day and your short visit time with them. So thank you. We're on our last few minutes of this program. Anything additionally that Daniel or Jenny, you want to add, from what we've talked about?
Well, you kind of asked what family and friends can do to help. Mm-hmm. And I think the thing that they shouldn't do is say, if you need help, give me a call, because that patient will most likely never call you. So what things Daniel said earlier are, sometimes patients, and Daniel discussed this too, sometimes patients are in denial, and sometimes they just don't want to hear anything about it. But what I found is the patients that there's this kind of transition that you have to make mentally to get yourself to a point where you can self-advocate, helping them get to that point. Like, you're going to have a better outcome if you know more. You can go into the clinic with better questions for your doctor. You can say, why are you doing this treatment over this treatment? Actually understand what he's saying to you or she is saying to you, to be able to self-advocate. So you are dealing with your life, and sometimes those things are really important on the education side. So sometimes people can do education for you or research for you about different options. Sometimes it's as simple as, this patient is going through a stem cell transplant. I'm going to bring over a whole bunch of freezer meals. And whatever, even if you can't eat it that day, your family can eat it, or you can save it for later, or just kind of noticing, do you need a ride to the clinic? My friend the other day, I was in an infusion. She's like, oh, you're going to be there for multiple hours. Can I come and just sit with you in the clinic? And at first I wanted to say, no, don't worry about it. I'm fine. But it was so nice to have her sitting there in the clinic with me. And that's kind of unusual with COVID, right? Because we've been sort of locked down from all of that. But it takes some effort. And like Daniel was saying, kind of some, like, you have to really get to know the patient to know what's going to be most meaningful for them. But yeah, I think those are some things that family and friends can do for you.
And just tapping into your friend's expertise. Some people are financial wizards and are very good in website, finding out the right ways to get benefits. Not everybody can navigate the insurance process. I still can't. So I think, having somebody who's really savvy in your group that says, oh, I know how to do this, or I'll call your insurance company and I'll see exactly what your benefits, so you're not surprised with the bill coming in. So it's knowing who's around you too as a group. I think it's important, because, and that old saying, it takes a village to raise a child, that really does it takes a whole healthcare system to care for one cancer patient. It's something that nobody should do on their own across the board.
Right, absolutely. No, thank you so much for those, closing ideas. We don't have any questions in the queue, but if there are any, please type them in. In my preparation for today, there was a couple of things that were really meaningful. I hope they are for anyone listening in. And one of those is to support the fighters and the patients that we see before us, Jenny, and our healthcare providers and Doctors Tantra, Vahima, Dawn, and Verena. So support the fighters, admire the survivors. That's Jenny too in front of us here today. Honor those who have been taken, because all of us have those patients that reside in our heart and continues to focus on what our why is and what we do every day. So honor the taken and never, ever give up hope. And then one other thing I found was by ESPN anchor Stuart Scott. He said, "You beat cancer by how you live, why you live, and the manner in which you live." And I just hope, again, all of us, I think, have a heart of caring and compassion. And I just want to thank y'all so much for this wonderful conversation and for joining me today. I hope everyone found this time to be informative and meaningful. I'd like to say a special thank you to each one of you in doing this with me today. And as we continue through Blood Cancer Awareness Month, we encourage everyone to keep learning about these hematologic malignancies as we all passionately work to continue to battle cancer. This session was recorded. Please visit our website and follow us on all social media platforms for more information on any upcoming events. We hope to see you again for one of our webinars, and thank you so much for joining us, and enjoy the rest of your day.
Thank you.
Thank you.
Thank you.